Welcome back to Corium. I'm Brian Gilberti, and today we're tackling a true you can't miss endocrine emergency, and it's rare, it's high stakes, and if you don't recognize it, then the mortality is staggering. And to tackle this topic, I'm joined by one of our chief residents, Dr. Annaliese Elam, to break down the management of thyroid storm. So Annaliese, thanks for being in the studio with us.
Thanks, Brian. I'm excited.
Now, as we usually do on this show, we like to set the stage with a case. So why don't you tell us about a case?
Okay, picture this. You have a 42-year-old female. She walks into your ER. She does have a known history of Graves' disease, but today she's coming in because for the last 3 days, she's complaining that her heart is just racing. It's jumping out of her chest. You know that she's febrile to 104.2. She's tachycardic with rates in the 150s. She's very agitated. She's pacing around the room. She's speaking incoherently, and her skin is warm and moist.
Okay. All right, good. So classic presentation, short and sweet, but really hit all the points there. But now let's flesh it out a bit more. What else should we keep an eye out for on exam when these patients come through the door?
Yeah, so a lot of times these patients will have a known diagnosis of Graves' disease. About 30% of them will already have diagnosed Graves prior to this. But there's usually some precipitating event that causes them to go into full-blown storm, whether this is an infection, a recent trauma, did they just lose their prescriptions and stop taking their meds? Even taking amiodarone, initiating a new medication can cause this, so thinking about what popped them into it. And then clinically, something that you want to look for in the physical exam is the fact that they're altered. This might be the only thing that looks different in somebody who is in true thyroid storm versus somebody who's in a thyrotoxicosis or a compensated hyperthyroid state.
Now, on the show, we really like to nerd out and get into the weeds and get technical here. So let's do that and talk about how a patient goes from just being hyperthyroid to a full-blown storm. And what are we looking for in the labs that we typically send?
Yeah, pretty interesting in a patient who's just hyperthyroid versus thyroid storm. They might have very similar, almost the exact same TSH, T3, and T4 levels. So there's no number cutoff that's going to tell you that this person is in thyroid storm. This is a clinical diagnosis. There is an increase in the serum levels and the activity and the peripheral responsiveness to the catecholamines. So that's what's driving it. And T3 is really the hormone here that's going to be causing all the organ dysfunction. So the T4 is not the active one. And we'll get into this later in the medication section, but the T4 to T3 conversion, we're going to try and block a lot of that since T3 is the one that's manifesting all these issues.
Okay, important point. I'm glad that you highlighted that. Now, when we see these patients, they're really on a spectrum. So I was hoping you can walk us through how we determine where they are on that spectrum.
We love our clinical scoring tools in the ER. So we have the Birch-Wartofsky scale, which is going to help you guide what your level of suspicion is, though important to note that this is, again, not the thing that's going to diagnose them. So the Birch-Wartofsky scale, you can find it on MD Calc, our favorite little handy-dandy notebook. But it takes things into account, like what's their temperature, what's their heart rate, are they in AFib, do they have heart failure, and are they altered, and to what level? And combining all of these will give you some output score. If they have 45 or more, this is highly suggestive that they're in storm. Score of 25 to 44 suggests impending storm, though in a study that I read, about 20% of people who had a clinical diagnosis of thyroid storm fell into this bucket. So just because they're in the middle range doesn't mean that you should rule it out. And then a score below 25 makes storm quite unlikely. But also important to think about a lot of patients that you see, somebody who's uroseptic, somebody who just did a bunch of cocaine and is pathomimetic, they will screen positive on this. So this is a sensitive tool, but not specific. So you might have other patients in your ED that technically would meet the criteria on the Birch-Wartofsky scale, but are not necessarily in thyroid storm.
Excellent, Annaliese. And you highlighted two really good points here. One is that there's no firm cutoff here, that this is really just guidance for us. And ultimately, we're going to have to make our decision as clinicians. And two is there could be some overlap with other processes. It's going to be unclear sometimes whether this person is septic, whether this is thyroid storm, or if they're septic and that caused them to be in thyroid storm. Now, we already talked about the TFTs, the thyroid function test. Let's take it a bit further and tell us about what else we might see on the labs when they come back.
Yeah, so you can see a whole spectrum of different things here. Things to look at would be their sugar. So you can both see hyperglycemia just because of all the catecholamine-induced insulin inhibition, but also they're in a really high metabolic state. So conversely, they might have low blood sugar, so you should be definitely getting finger sticks on these patients. You might have abnormal liver enzymes. People can actually present, frankly, in jaundice. So the T3 can have direct hepatocellular injury, and it can also cause cholestasis. So looking at your LFTs is important. Leukocytosis, thrombocytopenia, hypercalcemia, all of these. And then we already mentioned, but sending like a broad infectious workup to screen for an infectious trigger to why they went into storm.
Okay, all right, good. So that rounds out our diagnostics here. And time to move on to treatment. And this is another part where we should really highlight on this episode that it's not straightforward here. It's really a multi-step process. So walk us through the blocking strategy and tell us where our priorities should be.
You want to get beta blockers on board pretty quickly. Usually we reach for propranolol first, both because of the beta blockade to improve the heart rate, but also because it blocks the peripheral conversion of T4 to T3. If you choose this, it's going to be a dose of 60 to 80 PO every 4 to 6 hours. But I would also mention that this patient might be manifesting in heart failure. And even though this is a high output heart failure, which will be probably improved when you control their rates, I think esmolol is a good alternative option. Fast on, fast off, very titratable. So whichever one, some beta blocker, you're going to get that on board quickly.
Okay, good. So that's our beta blocker. Now let's move on to how we're going to be controlling the production of new hormone. What's the game plan?
Yeah, so really the heart of the issue, we need to stop the hyperthyroid. You can either choose propylthiouracil or methimazole. We usually choose PTU in a storm because it also blocks that T4 to T3 conversion. And PTU will decrease your T3 levels by about 45% within 24 hours, whereas the methimazole only drops it 10 to 15%. So for PTU, you're going to be giving 200 to 250 milligrams every 4 hours. And then of note, both these medications are oral only. So if your patient comes in and they're vomiting, intractable, you can't keep it down, this might mean that you need to put an NG tube in, give it to them that way, or you can formulate it in a rectal form and give it that way.
Okay, good. Great, Pearl. Now we're on to our iodine step. And there's an important timing issue here that we have to underline. So tell us about that.
Yeah, so in the ED, a lot of things happen in parallel, but really importantly, this does not happen in parallel. This is a stepwise process. After you've given your PTU, you need to wait at least 1 hour before you give them iodine, as this can actually precipitate a worsening thyroid storm. When you give the iodine, it can either be Lugol's or SSKI, which is just potassium iodide. But really, really importantly, you have to wait at least 1 hour.
Okay, now we've covered beta blockers, thionamides, iodine. Now let's tackle steroids and the rest that's going to be in our miscellaneous bin.
Yes, this patient also will probably have some adrenal insufficiency on top of their thyroid storm, so we want to get steroids on board pretty quickly. You will load them with 300 milligrams of hydrocort and then give them 100 IV every 8 hours. In terms of their hyperpyrexia, you want to control that with cooling blankets and acetaminophen. We want to avoid aspirin because that can also worsen the T4, T3 peripherally, so that can worsen their temperature.
Yes, it is Q8, but hopefully they're going to be up in the unit by then, before the second dose. All this is really incredibly high-yield stuff, super dense, but if you can we distill it down even further for some take-home points for the listeners?
Yeah, the main thing here is really that this is a clinical diagnosis. We talked about the Birch-Wartofsky score. That's great, 45 and above, likely a storm. But this is really something that you're diagnosing based off of their symptoms. The fact that they have organ dysfunction and that they're altered is really what's going to differentiate this between thyroid storm and thyrotoxicosis. The timing is really important in your medication, so making sure that you give your thionamides, your PTU, at least an hour before you give the iodine. Thinking about blocking, so a lot of the medications we talked about block the peripheral conversion of T4 to T3, so propranolol, PTU, and then your other medications too, iodine, steroids. They're also very volume down, so you want to give them a lot of crystalloid. Help support them that way. And then the last point is just to avoid aspirin. So obviously you need to control these people's temperatures, but you want to choose cooling blankets and acetaminophen, and you want to avoid aspirin.
Perfect. And as always, check out the show notes because we listed a bunch of numbers and tables. All the resources are going to be there in the show notes. Annaliese, thanks for joining us in the studio.
Thanks so much for having me. And last clinical pearl, very importantly, I just wanted to give a shout out to Linda Fountain. Thanks for listening.